All right, let's dive into this explainer and hack the incredibly dense world of antibiotic pharmacology to help you absolutely crush your nursing exams. Look, if you've ever stared at a giant list of antibiotics and felt completely overwhelmed, you are definitely not alone. It's a massive topic, but we're going to break it all down into a highly structured roadmap so you can walk into that exam room with total confidence. But first, I want to hit you with a classic board question. Do you know which drug class demands strict trough monitoring to prevent permanent hearing loss? Just keep that in the back of your mind as we go through this, because by the end of this explainer, you won't just know the answer, you're going to understand the exact mechanism behind why it happens and exactly how to prevent it.
To memorize these massive drug lists, we have to bucket them by mechanism of action. So here's our roadmap to categorize and conquer. 1. Cell wall destroyers. 2. Protein synthesis inhibitors. 3. Folic acid and DNA disruptors. And 4. High-yield toxicities.
Okay, kicking things off with Section 1, cell wall destroyers. These are the antibiotics that completely dismantle the bacterial cell wall.
Now, there's a core difference in how antibiotics fight, and you really need to understand this fundamental rule. Antibiotics are generally either bactericidal or bacteriostatic. Bactericidal drugs, like our cell wall destroyers, they don't mess around. They directly kill the bacteria. Bacteriostatic drugs, on the other hand, just inhibit bacterial growth. They kind of stall the bacteria out so your patient's own immune system can come in and finish the job. And since human cells don't actually have cell walls, drugs that target the cell wall are usually incredibly safe and effective for us.
Let's talk about the granddaddy of them all, penicillins, which includes your amoxicillins and ampicillins. Penicillins are classic bactericidal agents. They literally slide through the bacterial wall, bind to specific proteins, and disrupt the synthesis of that wall. The result? Actual lysis, or rupture, and death of the cell. But from a nursing standpoint, your primary assessment must always center on monitoring for severe hypersensitivity and anaphylaxis. Oh, and here's a sneaky exam fact for you. Check the IV preparation. Some penicillins contain large amounts of sodium or potassium. So if your patient has heart failure or renal issues, this can trigger dangerous hyperkalemia or hypernatremia.
Moving on to cephalosporins, we categorize these by generations. And the key trend to memorize is that as pharmaceutical scientists created successive generations, the level of gram-negative coverage increases. So your first-generation drugs like cefazolin and cephalexin, fantastic for gram-positive bacteria. But by the time you step up to the third generation with ceftriaxone, you're getting extensive gram-negative coverage.
Now, major safety alert here. Because their chemical structures are practically identical, there is a 1 to 4% incidence of cross-sensitivity between penicillins and cephalosporins. So the crucial takeaway is this. If a patient has a history of just a mild rash with penicillin, they might just need close monitoring. But if they have a life-threatening anaphylactic allergy to penicillin, absolutely no way. They should not receive cephalosporins.
Rounding out our cell wall destroyers, we've got the carbapenems, like imipenem. These guys pack a punch with the broadest antibacterial action of any antibiotic to date. We generally reserve them for acutely ill hospitalized patients who have complicated body cavity or connective tissue infections. They absolutely must be infused slowly over 60 minutes. But here is your high-yield exam gold. Carbapenems carry a risk of drug-induced seizures. It actually happens in up to 10% of patients getting high doses. Always assess your patient for a history of seizures, and make sure you check their renal function, because poor kidneys definitely increase that risk. All right, Section 2, protein synthesis inhibitors. Let's see how these next classes build on our framework by attacking the bacteria's ability to create proteins.
First up in this group, the macrolides. Think erythromycin and azithromycin. Now, these are famous for causing severe GI upset, so you definitely want to advise patients to take them with a small snack to reduce that irritation. But beyond the stomach, you must assess baseline heart function. Why? Because macrolides are notoriously linked to palpitations, chest pain, and very specific ECG changes, most notably QT prolongation. Honestly, if you see QT prolongation on a question about an antibiotic, your brain should immediately go to macrolides.
Next up, tetracyclines, like doxycycline. They provide fantastic broad coverage for skin, GI, and respiratory infections. But man, they are absolute divas when it comes to drug interactions. Tetracyclines will chemically bind or chelate to calcium, magnesium, and iron. This literally ruins their oral absorption. So, you have to instruct your patients to strictly avoid dairy products, antacids, and iron supplements during therapy. If they absolutely have to consume them, they need to be spaced out by at least 2 to 3 hours.
And nursing exams love tetracyclines for two highly specific adverse effects. The absolute highest yield exam fact is that they cause permanent mottling and discoloration of tooth enamel in fetuses and young kids. Because of this, they are strictly contraindicated in pregnant or lactating women and in kids under 8 years old. On top of that, they cause severe photosensitivity. Your patient absolutely must take precautions to avoid sun exposure and tell them to completely steer clear of tanning beds.
Quick break! If you're finding this explainer helpful for your pharmacology finals, make sure you hit like and subscribe to the Nurse Crush It YouTube channel right now. We break down all the hardest nursing concepts just like this, making sure you are totally prepared to pass.
Okay, Section 3, Folic Acid and DNA. Let's look at the antibiotics that disrupt the synthesis processes bacteria desperately need to replicate. Remember that bacteriostatic versus bactericidal rule we talked about? Well, here it is in action again. Sulfonides act as bacteriostatic antimetabolites. They basically starve the bacteria by preventing the synthesis of folic acid. Quinolones, like ciprofloxacin, take the exact opposite approach. They are extremely potent bactericidal drugs that go straight for the kill by completely destroying the bacterial DNA.
A highly tested sulfonamide combination is SMX-TMP, or sulfamethoxazole trimethoprim. It's super common today for outpatient staph infections, respiratory tract infections, and community-acquired MRSA. Now, the absolute genius of this drug is its safety profile when it comes to human cells. See, it stops bacteria from synthesizing their own folic acid. But humans, we get our folic acid from our diet. It's exogenous. Because we don't synthesize it ourselves, the drug doesn't mess with our human cells at all. Pretty cool, right?
Moving on to Section 4, High-Yield Toxicities. Now for the climax of this explainer. These are the life-threatening red flags every single nurse needs to know by heart.
We're bringing back the drug from our intro question, aminoglycosides. We're talking drugs like gentamicin. These are incredibly potent bactericidal antibiotics, usually reserved for really serious infections, but they come with a massive high alert warning for patient safety. The duration of therapy has to be kept as short as possible because the toxicities are severe.
You need to burn this into your memory right now. Aminoglycosides destroy two things, the kidneys and the ears. Nephrotoxicity hits the kidneys, which you'll see as proteinuria and increased BUN in serum creatinine. Fortunately, that one is usually reversible. But ototoxicity is a totally different beast. It damages the 8th cranial nerve, leading to dizziness, vertigo, and hearing loss. And tragically, this is often permanent. To prevent these toxicities, your critical nursing interventions are non-negotiable. You have to aggressively hydrate the patient, pushing up to 3,000 mL a day if it's not contraindicated, just to protect and flush out those kidneys. You need to consistently monitor BUN, GFR, and serum creatinine. But the single most important intervention, meticulously monitoring serum trough drug levels. If that trough level gets too high, the drug isn't clearing the system, and your patient is on a fast track to permanent hearing loss. Note their baseline hearing and ask them daily if they're experiencing any ringing in their ears or dizziness. Similarly, when you're administering our folic acid blockers, the sulfonamides, you have to be on high alert. You must push fluids here too, again around 2,000 to 3,000 mL per day, to prevent crystals from forming in the urine, which is a condition called crystalluria. You also need to consistently assess their skin. Sulfonamides carry a high risk for Stevens-Johnson syndrome, which is a severe, blistering, and potentially fatal rash. And finally, get a baseline red blood cell count, since these drugs can trigger severe anemias.
I want to leave you with a clinical reasoning question based on everything we've just covered today. If your patient on an IV aminoglycoside starts reporting a new feeling of dizziness and fullness in their ears, what is your very first nursing action? Think about what organ is being targeted and what that means for the drug levels currently in their blood.
Drop your answer in the comments below. Remember the golden rules here? Safety first, aggressively hydrate, protect that 8th cranial nerve, and always check your troughs. Keep studying those mechanisms of action, go out there and crush your exams, and I'll see you in the next explainer.